talk about the Kawase approach. This is a skull-based approach which we sometimes use in our center in the Netherlands. It's one of a series of very complicated approaches which you can do for lesions that are located in the posterior fossa. So what we're doing right now is we're coming from the stellar and paracellular anatomy, and we're going through middle fossa, and we're coming back in posterior fossa with the fourth ventricle presentation. This is also a presentation I did together with my mentors, Dr. Damas and Dr. Dillen. The cases you will see that I will present a couple of operations today, more than yesterday, and they're all Dr. Dillen's cases. He's one of our, he's the best skull-based surgeon we have. And, you know, let me make an introduction. The Kawase approach is so difficult and it's so technically challenging that if you don't work in a lab at least, I would say years before you do it, you will never be able to master it correctly. And because it has such high risks, I think it would be actually irresponsible to operate on a patient before you've tried it in a cadaver. And if you've tried it in one cadaver, it's never enough, because the technical finesse and the understanding of anatomy that you need to do a proper Kawase is so complex that you won't be able to master it unless you time and time again come to the lab. So what I'm trying to say is, you know, see what the masters do, take a look at those who've reached higher levels in neurosurgery. They've all had a passion of going into the lab and dissecting an anatomy, and then they went to neurosurgery. So that's where it all begins. And especially in posterior fossa approaches and in the Kawase approach, that is per excellence approach where anatomy is the most important thing that you have. This is a drawing by Dr. Delgo himself, which is also proof that a skull-based surgeon, and that's especially true in Japan, a skull-based surgeon can and should also be a very good drawer. And what you see here is the temporal lobe and temporal pole being elevated on the right side, and this is the divided tentorium. You see here the divided edges of the tentorium, which are suspended by sutures. And what you see here is actually the exposure and the extent of the exposure of the Kawase approach. So what you're doing is you're coming from middle fossa and you're drilling out the petrous apex, and then you're coming in posterior fossa. This is the underside of the petrous apex going towards foraminal valley here. This is a Viscerian ganglion with Meckel's cave, V3, V2, V1, foraminal valley, foraminal tendon, and the basilar artery with the ACA and ICA. And what you also see here is fourth nerve inside the tent here, and also obviously the root of the trigeminal nerve going into the pores trigeminus to reach Meckel's cave. So this is the extent of your exposure. And when you begin an anatomy, then you can also guess already what you're going to be using it for. Because why would you use such a complicated approach if you don't have a very good reason? Why would you use such a complicated approach if you could go for instance, retrosigmoid and come at the exact same place? Well, when you're using retrosigmoid approach, you're usually coming up all the way to the fundus of the meatus, pores and fundus. You can drill them out and reach them both. Over the meatus there's a crest called the suprameatal tubercle, and you can drill that out for more space, and then you could also reach from inferiorly the root of the trigeminal. But if you want a more bigger exposure, if you want a larger exposure coming from above to the side of the clivus, then you're going to need a Kawase approach. And another important thing about the Kawase approach is this is an anterolateral approach as opposed to a posterior approach. So if your lesion is situated, for instance, here on the front side, the anterolateral side of the brainstem, if your lesion is situated somehow more on the side of the clivus, as is often the case with petroclival meningiomas, which are one of the most challenging lesions a neurosurgeon has to face, and I'm fully agreeing with everybody that says that petroclival meningiomas are something that not everybody should be doing. You should only be doing petroclival meningiomas if you're a master in skull base, if you've mastered all the techniques, and especially if you can manage the complications and the invalidities that come with it. Because that's a very important thing that nobody talks about. I mean, you can start operating on petroclival meningiomas, but if you're not good enough in everything, in all the skull base approaches, in all of this very, very complex anatomy, which is also being changed by the lesion, because you have here a very big petroclival meningioma extending on the back side of the trigeminal nerve and compressing the brainstem, then you're going to have a giant bubble, a giant ball, golf ball, that's compressing here the basilar on this side, the trigeminal nerve is bulging out, brainstem's compressed. So what you have to do is you have to work around all these very complicated structures, and that's really not something anybody should do. That is, that I also told you that yesterday, that's only for the most specialized skull base surgeons, and I think that all neurosurgeons should subspecialize. And that's something that Abdullah always says, and that's something I also believe in. I think it's the only way we're ever going to get proficient enough to operate on very complex lesions such as the petroclival meningiomas without the morbidity and mortality which are associated with them. And it's not so that you can treat like, cavernous sinus meningiomas, you can use stereotactic radiotherapy, because you could, but the patients often come with severe cranial nerve palsies or even signs of brainstem compression. So you're going to have to do it. Somebody's going to have to decompress that lesion. And if you decompress that lesion, you might as well take it out, because entirely, do a gross total resection, because it's proven time and time again that gross total resection, a Simpson's game, a Simpson's zero, is, it's not really feasible that you're going to do a Simpson zero here, but you can at least try to achieve one. But it's been proven time and time again that the gross total resection is the one most important factor that's going to influence meningioma recurrence. So if you don't want to see that meningioma again, if you don't want to see your patient again on follow-up with a giant ball in his head again, and signs of brainstem compression, then you were going to have to try to do gross total resection. And what you see sometimes is that people try to go into petroclival meningiomas, and they find out it's very difficult, even in a benign lesion. I'm not even talking about very infiltrative grade 3s, but even in a very benign lesion, they go in and they take out 25%, it just looks like a big biopsy instead of a resection, and then the patient's not better. But what they did is they created an entry point with fibrosis. You have fibrosis of the meningioma, you have all these structures that are now attached to one another. There's not really an arachnoid plane which you can dissect properly. So what they did is not only did they not achieve a good resection, but they actually made it more difficult for the next one who's going to try to do it to actually do it properly. So in my opinion, somebody who's going to operate on petroclival meningiomas and who does not have the skills to do it is actually hurting their patients. They're not even making them better. It's not even, it's irresponsible to do it. And that's something very important that you should keep in mind. Do not operate on something if you're not qualified enough to do it. If you don't have all the skills necessary, do not begin operating on a lesion. And this is not something, some extremists can draw the conclusion here, okay, so only the professors have to operate because they have the most experience. That's also wrong. Trainees have to operate, and trainees have to be trained, because that's why they're called trainees. But when you're training, you have to know your limits, and you have to know what area of expertise you're going towards. And the really difficult lesions, you either have a senior that's near you and that can take over when you're not handling it properly, or you're qualified enough to do it and then you begin on it yourself. So don't ever begin on operating on a lesion. That, if you take home nothing from what I said, but this, I'll be happy. Don't operate on a lesion unless you're 100% sure that you're going to operate on it properly and you're going to be able to solve all your complications yourself. That's why I have a problem with specialties, and that's just my personal opinion. I'm not judging anybody. But that's why I have a problem with specialties that require some other specialty to jump in if they're causing a bleed or a complication. I'm not going to give names. So anyway, this rant aside, if you're doing a Kawase approach, you're probably having a petrocleidomeningioma or another lesion, a trigeminal neuroma or a trigeminal neuroma that's been turning into MPNST, and that's so a malignant peripheral nerve sheath tumor. That's sort of that's not a sort of that's a malignant schwannoma, and it's growing in the posterior fossa. Sometimes it's actually eroding the petrous apex, so you're doing less work. So you're operating on a lesion in the middle fossa, who also has an extension in and towards the posterior fossa. And so what you want to do is you want to have a very short, small, but wide enough approach. So you want to make sure that the way you're approaching this lesion is the smallest, safest, but with the biggest exposure. And that's what actually Kawase did, and that's why he's so famous for his approach, because the idea is brilliant. And when it comes to petrous bone, it's virtually impossible, unless you're, I don't know, Fukushima or a couple of others in the world, to do a petrosectomy, so to resect the petrous bone without causing damage. Because in the petrous bone, you have everything that's going inside. You have the meatus, you have the carotid, you have cranial nerves, GSPN, Vidian nerve, you have all these other structures which are lying on its frontal and lateral sides, like the infratemporal fossa, the temporal fossa. You have mastoid, facial nerve, most important. If you cause a facial nerve palsy in the petrous bone, then your patient will have a House-Brackman 6 facial palsy. Do you know what that looks like? Like this. Every day in the mirror, they're disfigured. There are people that are going to commit suicide because you've cut a nerve. So you have so many anatomical structures in the petrous bone that it's virtually impossible to do anything with petrous bone without an amazing amount of experience, without damaging something. So I think the most important thing of the Kawase approach is that Kawase managed to think of an approach which was safe, which had no really important structures only around the petrous apex, and which offered still a wide exposure, wide enough for you to be able to operate on your lesion inside it. And this is all based upon this measurement. So what we're seeing here is a skull base, obviously. This is the anterior fossa with the crista galli. We've talked about length, I think, yesterday, about the anterior climate process, superior orbital fissure, optic canal, dorsum celli, posterior climate processes. You see that the patient does not really have a very wide and steep chiasmatic sulcus as we've seen yesterday. So you would be looking here for tuberculum semimeningeal still on the lateral side. But now we're going to focus on pitchus bone here, and clivus, foramen magnum, and I'm curious, do you guys know what this is? Yeah, it's the jugular foramen. And what would TJ be actually then? Yeah, that's a tuberculum jugulare, indeed. And it's funny because, you know, this is tuberculum jugulare and this is the hypoglossal canal. You have the canals here. And one of my favorite skull-based approaches, and the most difficult in my opinion, is taught of by Professor Fukushima. And it's really, if we're ever going to talk about it, I mean, it's the most complex I've ever seen and the most difficult to do. And it's called the elite approach, and that's called the extreme lateral infrajugular, because you're coming to this area here, tubercular transcondylar exposure approach, elite. So what you're doing is you're coming from lateral, and you're going to drill this entire thing out, and you're going to expose lesions here. Why is this so difficult? It's because you're coming from this exposure and you're going to have to drill out here, whereas the 12th nerve, 9, 10, 11 and the jugular vein all come on this side. So you're working between very, very important structures. I mean, even more than a Kawase approach, an elite approach. Now that's something I think only a few people in the world can actually do it and be safe with it, because you can do it, don't get me wrong, but you can also find out that you have 9, 10, 11 stuck to your drill. And then your patient's going to get a tracheostomy because he's not going to be able to swallow on his own. But I digress. So it's based on the measurements of these two lines. The first line is on the underside of the dorsum celli. The second parallel line is at the level of the pores, the underside of the pores, and then the last line is on the front side of the tuberculum jugulare. So what you see here is one of Professor Kawase's studies, which showed that this is the extent of the exposure for a Kawase approach. So from here all the way to here, you can approach lesions with a Kawase approach. All the way to the underside of the pores, especially if you do a House approach, named after William House, the doctor who introduced wide mainstream microscopy, and he was an ENT surgeon. And the House technique is opening the meatus, but not from porus to fundus, as is most safe and most usual, but from the fundus to porus. And that's very complex because it's very likely if you don't have enough experience, it's very likely that you will injure the nerves at the fundus of the meatus. But I think we're going to be talking about that in another session. So this is the extent of the exposure, especially if you're also opening here the meatus. So any lesion that's situated here, you can approach with a Kawase approach, and you're also coming from anterolateral, so you're not going to be working very difficult between all these nerves and fibers and arteries. Now the K2 line is the extent of the retrosigmoid approach, which obviously does not cover underneath the tuberculum jugulare. You have an elite approach or a ferolateral. You'd need such an approach for that. So just a cadaver dissection. What you're doing is here's ear. You're going to be opening this flap, and then above the ear you're going to be doing this craniotomy. And what's very important is 3D anatomy. So you have to be oriented at the moment, because there will come a time when you will be faced with a cadaver head, And you're going to be at a course, maybe the Rotterdam skull-based course, just doing a bit of marketing. But no, really, it's a brilliant course with Professor Christ himself coming to show us everything. So you'll be faced with a cadaver head, and you're going to be you're going to see a presentation. I'm talking about Capra sinus or approaches, and then you get your own head together with a colleague, and then you're going to be faced with the prospect of drilling something. You're going to have to I don't know, do it yourself, and only at the moment that you open are you going to realize how complicated this all is. Because in your head it's clear, and the photos in Rotterdam are beautiful, and these pictures are wonderful, but only when you open it for yourself will you realize how difficult this all is. So you need to be very well prepared and have in your head at least a schematic of the anatomy that you're going to be coming across. You know, in all the dissections that I've done, and in all the anatomy that I've studied so far, the only thing I've learned is expect it to be different every time. I mean, it doesn't matter how many heads you've dissected, it doesn't matter how many dissections you've done. This is a motto that I'm going to put on my PhD. Expect it to be different every time. And this is also true for the Kawase approach, because you know maybe you've done it enough times, and then you go and you see a picture apex, and it's totally different than everything you've expected so far. So be prepared for everything is a message. And also, this is a craniotomy. Yeah, this is the divided temporal muscle, and this is a spatula on the temporal lobe. And then this is your line of sight, because the patient will be positioned with his head 90 degrees, so parallel to the floor. And this is your line of sight. You're going here. And what do you think this is? Anyone? It's like, you know, it's something sticking out of the bone.
Arcuate.
Yeah, it's the arcuate eminence. So this is cochlea, this fundus, studiatus, pores, middle ear, and this is the labyrinth with the semicircular canals. And the superior semicircular canal causes a bony ridge, a bony prominence in the floor of the middle fossa, which is very important because it will save you a lot of trouble when you're getting in and it's all bloody, because everything's bloody. This is very well vascularized, a lot of diploid veins, it bleeds all the time. You're going to see it in a minute. So, arcuate eminence, very important, very important. Always identify the arcuate eminence. And then what I told you yesterday, because you're going to be, what you're going to do in all middle fossa approaches, you're going to be peeling off the dura. That's always step one, peeling off the dura, as you see here. And then, what is this? What is this? What do you think this is? Because you know, you're peeling off the dura and you're coming here and you're going to drill this out a bit more on the front side. But what is this? Because this is standing in my way. What is this? It's a tentorium, huh? This is tentorium. It's like, you know, it's like this. It's like a tent, and this is the hiatus, huh? and brainstem. And what is a very important landmark that's separating the middle fossa from posterior fossa? It's the tent. You have to divide the tent in order to come to posterior fossa. And if you remember this drawing where I ranted about, this is the divided tentorium. So you're dividing the tentorium. That's an important step. Okay, you know, you're here to learn. If you don't know, you're gonna find out. It's important that it's important that you have some concepts before we get into the actual dissection. So that's why I'm asking these questions. You get some landmarks. And while we're on the topic, let's see, what is this? It's a cranial nerve.
The fifth nerve.
Yeah, it's the fifth nerve, so very important. It's the root of the trigeminal nerve, and you're coming here and you're exposing this when you're doing your dissection. Very good. All right. And okay, what is this? I would agree with you, but it's a bit too high, I think, because it's almost coming towards the trigeminal nerve. And also very important, and this is going to be a landmark when we're talking CP angle, is it's around the nerves which are at the porus fundus, so it's ICA. Yeah, and that's important because ICA aneurysms are a very important indication to do a Kawase. And if you look at WNS YouTube channel, which is all free, you can see a Kawase and ICA bypass by Lawton, which is a very good example of what you can do and how interesting and feasible the Kawase is. Okay, so it all started obviously in 1965 with Dandy, because everything starts with Dandy, and he, you know, Dandy was such a imposing figure. I'm pretty sure you've heard of stories about Professor Arseni. Now, Dandy was like 500 times worse and better at the same time, because he was a ruthless leader. He was operating non-stop, Saturday, Sunday. You know, rounds at 5 o'clock and then at 6 going into the operating room, and he has a cult following. There are some neurosurgeons, and I think I'm one of them, who think that Dandy was an amazing neurosurgeon, that his model is excellent. And he follows a bit in the line of Cushing, but what's interesting about them is, you know, Cushing and Dandy never really got along because they were both so smart and so talented that they couldn't really be, you know, they couldn't really get along. But they developed the field amazingly in different ways, because Dandy, he actually was an aneurysm surgeon also. Cushing was not. He was mainly a tumor surgeon. And if we're talking about Cushing, when you become a trainee by Cushing, you have to sign, and that's something people that are working in Brigham and Women's know a lot. You actually have to sign a paper saying that you do not have a relationship and that you will not get married during your training. Yeah, it sounds like a joke, but it's actually true. That's what he did. He wanted people who would be more than 100% dedicated to the cause. So that's something not many people have. So the first thing about subtemporal approaches, because this is middle fossa subtemporal approaches, the first one who thought about subtemporal approaches is Dandy, and he thought about, you know, lifting up the temporal lobe as high as possible and then dividing the tent, but not at the Petrus apex, just dividing the tent in half and trying to go in. And that obviously has a lot of morbidity and mortality, because you're lifting on the temporal lobe and you have vena lobae and other structures which you can injure, or just the temporal lobe itself. So it's that's not an optimal. Subtemporal approach is still used sometimes in certain indications. But in 1985, you have this paper by Kawase, a transpetual approach for aneurysms of a lower basilar artery, and it's actually a case report. It's not even no, it's more case series. It's not even it's not, you know, a new technique. She just said, okay, I was trying to reach the aneurysms of a lower basilar, because, you know, basilar bifurcation, that's a region which you can
approach with not that much difficulty. Basilar trunk aneurysms, on the other hand, middles, they're very difficult to approach. So he was trying to work out a more simpler way to approach them and to come directly on them and not work from lateral, all the nerves and all the arteries, and then work towards the front. So he was thinking, how we do that? And obviously the Japanese are very linked to Peter's bone. Hakuba is also a great professor who's done a lot of Peter's bone research. And they knew that the one structure in the Peter's bone who is devoid of other important structures is the Peter's apex. So they thought about how you could drill that out and come from middle fossa to posterior fossa and succeed. So what he did was a large craniotomy, and then these are the original paintings. What you see here is, this is the Petrus apex, root of 5 going to pores trigeminus here and the Meckel's cave. And then you see this, cavernous sinus, we talked about this yesterday. Inferior petrosal sinus and superior petrosal sinus going to sigmoid sinus. So he thought, you know, what I told you yesterday, because that's relevant, what I told you yesterday is the main sinus that drains the cavernous sinus is the inferior petrosal. The superior petrosal is not so important. So they said, okay, we're going to drill this out, but the tentorium is standing in our way. So what we're going to do is we're just going to divide the superior petrosal sinus. And there are obviously some technical nuances here because you can't really divide it everywhere, and sometimes if you're doing one of the crazy lateral approaches, extreme lateral or something, then you have to watch out because the vein of Labbe sometimes comes here in the superior petrosal sinus instead of coming here. So there are a couple of technical nuances which I'm not going to get into, but when and if we're doing a Kawase on a cadaver, then we'll have to talk about all the technical nuances, obviously. And this is actually his own drawing. You see here, it's his own drawing in this article, and he's trying to show us that we have here an aneurysm of the low basilar and the superior petrosal sinus. And he's divided the tent here, and he's gone in just above the pores at the level of the trigeminal root, which is also important if you're having to deal with pontine cavernoma, and you have, as we're going to see in a movie that I'm going to show you, pontine cavernoma, which is a very interesting lesion to operate with a lot of risks, obviously, because it's a pontine cavernoma, and you can use this route to gain access to the trigeminal safe entry zone, because around the trigeminal root you have less fibers, the cortical spinal tract that's just here. So if you're going in at the 2/3 posterior direction, then you're going to miss all the important fibers. So that's why it's called the trigeminal root safe entry zone. So you can enter the brainstem through that area without damaging important structures, if you have the right tools. And this is actually an intraoperative photograph. This is the pons, 6th nerve, and aneurysm in the basilar, and icon coursing here. So this is actually the original photo of his case. Then he thought, okay, how can we take this technique and use it for more complicated cases or other indications? So he thought, okay, petroclival angiomas, because you have the petrous bone and the clivus inside. Why won't we use it for that? So this article came out in '91. Same approach as you see. You have the labyrinth here, petrous apex. Gastrian ganglions here, foramen ovalis here, middle meningeal, geniculate ganglion. and this is where he's going to drill out. And then he came across an epidural tumor, and this is the drilling. This is Ica, foraminal valley here, and the tumor extending to Meckel's cave. And at the end, you have again the divided tentorium, and never forget this, you're going to have to divide the tent. Fifth, going to pores trigeminus, superior petrosal sinus, also divided here, and the backside here. Ica and the pons. Okay? And then he reconstructed it with temporal muscle. Because sometimes you have to do, mostly if you do this approach, you don't, the chances of CSF fistula are rather small, unless you open the tegmen tympani. You have no tegmen tympani. You open the mastoid cells, and if you do one of these, then you have to know it, so that means identifying it well before and thinking about these possible complications, and so you have this in your mind that it can happen, and then you have to identify that it's done and fix it, because otherwise your patient will have CSF fistula and will have the sensation that he constantly had water in his ear. And then this article came out, which is actually a very, very good article by Aziz and John too, Harry van Lover. For those of you interested, again, in the fine art of neurosurgery, John too, a grand master of foramen magnum tumors, Harry van Lover, the master, one of the masters of petroclival meningiomas. Just remember these two names, because the book they published, microsurgical book, it's very rare. You don't find it readily at every bookstore. I think even Amazon has a problem doing it. It's unbelievably expensive, but it's amazing. It's amazing. They describe very beautifully a ton of approaches to an amazing cohort of lesions. So it's something to remember, to and from over. So they actually co-authored this paper, Kawase approach to retrocellular and upper clival basilar aneurysm. So they extended the indication. They said, okay, you can do it for lower basal, you can do it for petroclival meningiomas, let's do it for upper clival retrocellular aneurysms. So what you see here is again the anatomical perspective, clivus, dorsum celli, inferior petrosal sinus going to sigmoid sinus, foramen ugulare, hypoglossal foramen, and porous, and fifth, and this is actually what you're going to be drilling out from the middle fossa, going to posterior fossa, and then dividing the superior petrosal sinus. And they actually did also a dissection, and you see here the result of this dissection, and you also see their manner of dividing the aneurysms into lower clival, mid clival. So the Kawase's first aneurysm will be a mid clival one, upper clival, and retrocellular. Yeah? And they actually used this technique with very good results. So what you see here is again same. They like to flex the head a bit more than we do. We just like it parallel to the floor. And craniotomy, spatulas on the temporal lobe, the GSPN, foraminal valley, the geniculate ganglion, and these are all very important landmarks which we're going to be discussing in a minute. And here's the Kawase triangle or trapezoid, and the divided tent with the anterolateral side of the breast. Anatomy. So this is middle fossa, obviously, and you're never going to see it so beautifully as here, because you're never going to have a head without a brain, hopefully, or something's going to be wrong. And what you have to do is first peel off the dura. Now, obviously, in this dissection, they peeled off the dura of everything, but that's not the idea. You have to peel off the dura beginning here, and you have to identify landmarks. This is the most important part of your surgery. Landmark identification. What's your first landmark, do you think, when you're doing this approach? The very first landmark, and you can't miss it because it's always bleeding. So you've done your craniotomy, and you want to identify your first landmark on the middle fossa.
Like
No.
immense, as you said.
No. It's bleeding. Yeah. Middle meningeal artery is always bleeding. Unless you perfectly manage to save it, it's always bleeding. So you need to divide it anyway. So you can just follow it's going on the lateral side of the dura. You can just follow it here, and you've reached your first and most important landmark, because it's the first one. And which is that? Middle meningeal artery, which stems from right here. No, it stems from I'm talking about the skull base. What does it stem from in the skull base? There's there's a foramen. Yes, foramen spinosum. So you've identified the foramen spinosum. If you've done that, then your first step is actually almost done, because the second step is identifying foramen valley. And that's very simple, because once you've identified foramen spinosum, so once you've identified foramen spinosum and you've divided middle meningeal artery and you've plucked it some bone marks or some Surgicel, then all you need to do is go anteriorly and a bit posteriorly, just anteromedially, and you will come across this fold of dura, which is V3, covering V3, and that's foramen valley. So you have spinosum and ovale are your two most important landmarks to begin with. And then once you've identified V3, and all you need to do is peel the dura away, and you see here the petrous segment of the carotid with the GSPN going above it and going to tetrapalmine fossa medial nerve. But you're identifying this region, and sometimes there's a dehiscence of bone above the carotid, which occurs in 30–40% of the cases, because you're going to see a pulsating mass. And once you see a pulsating mass, that's pretty okay, because the greater petrosal nerve GSPN is always running above it. So you don't have to do a lot of difficult searching from what is the GSPN. And then, very important, is you have to identify the geniculate ganglion. Because if you damage the geniculate ganglion, your patient will have facial palsy. Identify the geniculate ganglion, and then you've had your Kawase trapezoid. And you don't have to peel away the dura from all of this region. You don't have. That's not necessary. But what you can do sometimes, if you want a little bit more space, is unroof foramen valley, and then you can mobilize a bit the V3, and then you've immediately got more space here. We don't do that currently, but Professor Roche in Marseille, he's an expert at this, and he suggests it sometimes. So this is just the same view. Dura has been removed, GSPN over the petrous carotid, and you have the meatus that's been opened from fundus to porus, and you also have the cochlea and the cochlear angle. So if you're drilling in the petrous apex, the most important thing to know is, actually are, because 1, you should not drill inside the carotid. 2, you should not drill inside the cochlea. Your patient will be deaf. You should not drill inside the meatus unless you specifically want to. So you should not inadvertently drill inside the meatus. So in order to keep this simple. You only drill out this section. And how do you do that? I mean, where are the borders? Well, there are a couple of technical aspects which we'll discuss if we're doing this in a cadaver. But you're going to feel, you probably never drilled, but you're going to feel it in your drill when the bone composition changes. When you go from trabeculated bone, which is soft, where your drill goes very easily through, to very compact, dense bone. You're going, when you reach very compact bone, you're going to feel it in your drill. You're going to, you feel the difference immediately. So when you're drilling out the petrous apex, you're going to have to feel the moment when you're going from trabeculated, because that's the point where you're going towards the carotid. Not good. You're drilling. So when your patient's positioned like this, 90 degrees parallel to the floor, that means that you're drilling anteriorly as the patient is positioned instead of directly below. Because that's why you're positioning your patient with the head like this, because you want to drill directly below. Do not drill anteriorly. That's the, I have it as well. The tendency to drill anteriorly instead of below is always the first mistake and the first tendency. So don't do that. Also, when you reach very compact bone, it means you might be drilling too laterally because you're going to meatus, or you're coming on the last layer of bone before the posterior fossa dura. So that can be a sign that you're not necessarily doing something wrong, but that the posterior fossa dura is almost there now. The arcuate eminence has been a little bit drilled out, so you can see the superior semicircular canal, geniculate ganglion. So again, once you've done the craniotomy, first and always remember this. First and most important sign on the skull base, foramen spinosum. How do you know? It's always bleeding. What's bleeding? The middle meningeal. Just follow it back, divide it here, you have foramen spinosum. You have foramen spinosum. What do you do now? Well, you want to go a bit medial. So if your patient's like this, you're going to go posteriorly, and a bit anterior, and you're coming on ovale. If you have ovale, you just have to divide the dura here on V3, and you have GSPM and carotid. If you have GSPM, and you obviously have the external meatus because you've made sure that you can see it, it's obviously here, then if you draw a line from the external meatus, you see the internal meatus. And once you've drawn these two lines, then you know where the cochlear angle is. This is where the cochlea is, and you will never ever drill here unless you want to make your patient deaf. This is the best dissection that exists to this date of middle fossa, I think, except for Professor Fukushima's skull base atlas. Anyway, again, it's a left-sided middle fossa, cavernous carotid. We've talked about this yesterday. Fourth nerve, sixth nerve coming outside the Rell's canal underneath Grubel's ligament. Fifth, going through porus trigeminus and Neckel's cave. Petrous carotid, GSPN. Very important to know where the GSPN is. So again, middle meningeal, foramen ovale, V3, GSPN. You know where the petrous ica is. And actually this patient's position, just how we position our patients. Parallel to the floor, and what you see here, you have to drill downwards and not forwards. That's very important, complicated point. And also, Bill's bar, fundus of the meatus, and this is your area of interest. And from the self-article, the long axis of the GSPN and inner meatus, which you approximate by choosing the external meatus as a point of interest. And then there's a 60-degree angle, which is called the cochlear angle, where the cochlea is, and then you're going to drill out the petrous apex. Now, why would you choose the Kawase approach? I've told you this. So it's obviously for petroclival meningiomas or for trigeminal schwannomas, especially the aggressive ones, especially the ones that are growing to the posterior fossa, basilar trunk aneurysms, but also some basilar bifurcation aneurysm. It's not the one of choice, and ICA aneurysms, but also trigeminal microvascular decompression. If the ICA is making a loop that's going towards the root of the trigeminal nerve from below, then you might also want to try this instead of a Yanetta. The tumor of the pons or cerebellar peduncle, but which cerebellar peduncle? Because you can't approach all cerebellar peduncles via an anterolateral approach. Could you guess which cerebellar peduncle is? This is also linked to the following presentation on the fourth ventricle.
Middle one?
Middle one, yeah. So middle one's always outside. If you want to approach the middle one, you can't do it from inside the fourth ventricle. You have to do it from outside. And the superior and inferior ones we're going to see in the next presentation, they're lining the cavity of the fourth ventricle. And, okay, pathologies of the petrous apex, that's especially for ENT, but you might also be confronted with it, especially if you're working with ENT, osteotomas, chordomas, chondrosarcomas, histiocytosis, petrous epicytis, which is causing a Gradenigo syndrome, and metastasis. Now, the approaches that we've had in our center, and not in peripheral centers, because you can't just collect patient information from peripheral centers, 4 petroclivals, 4 lesions of the brainstem, 2 chordomas, 2 clival chondrosarcomas, some aneurysms, and some trigeminal schwannomas. We've had some extras. This is just till 2014. Now, what you can see is the good outcome is in 75% of patients. The poor outcome is in 2 patients, but the ranking scale stayed the same. They just presented too late, I think. And there were 2 deaths, and I'm going to talk about one of them in the following slides now. Complications. The abducens and the facial palsies, which are no worse than in House-Bregman 3, are occurring in 44% of cases. So, as you can see, this is not an approach without risks. And actually, 44% is pretty high. If you have 44% complications, that's almost 50%. That means that almost half of the patients that you're operating are getting something that they didn't have after the operation. But these 2, we followed them for a very long time, and these 2 always return. So the abducens, once you've seen it, it already has a palsy. Once you've seen it, you've also, that's the same with the trochlear nerve. But crazy enough, we don't have so many trochlear palsies as abducens palsies. But these come back all the time. The trochlear, not all of them, just 2 of them come back. These are getting better with time, and the facial palsies are going from House-Bregman 3, which is pretty visible, to most of them are going to a House-Bregman 1 within 3 months, but there are also 2 cases of people which had to have an intervention because the facial palsy remained. And as you see, CSF fistulas are 6 of 16, so 37%. It's very, very important that you manage this before you're going in. I want to present a couple of cases and a couple of films, because I'm pretty sure you're interested. So it's a 31-year-old female, very young. She came with eye movement and gait disturbance, headache and cerebral ataxia, and we see this well-delineated process in the pons. And when you're looking at this, you're saying, okay, it's very big. How should I approach this? Now, there are a lot of ways. I think there are some people who could have argued that they're going to do a retro sig here. We chose a Kawase, and I want to let you see. The lighting is a bit poor on this one. So what you're seeing here is already the drilling of the petrous apex. This is a cutting drill, and we're slowly drilling out what we've talked about so far. This is a patty, and here would be the place where Meckel's cave is. I guess here ganglion. T3 is about here. GSPN is on this side. Cochlear angle is here, and the meatus is here. So we're drilling out in the Petrus apex itself, and hopefully I won't get the annoying feeling about this. Yeah. Okay. So placing this patch on the temporal lobe again, and as I said, it's really important that once you drill out the Petrus apex, you have to divide the superior petrosal sinus and then the tent. And how do you do that? Because we're going to see in the last movie that the superior petrosal sinus can bleed a lot once you sit your bipolar on it. So the first choice is not ligation, is in our opinion is just bipolar it and see what happens, but sometimes you have to use Novoco or other techniques. Now you see the divided tent here, so we're coming on the ragna of the posterior fossa, which are going to be opening, and then what we want to do is we're coming on, and you're seeing this here, this is the brainstem. So we're coming on the anterolateral side of the brainstem, and what you see here is brainstem is usually dividing the air. The brainstem is usually very white, beautiful structure. But what you see here is there's like a spot on it. And once you have a cavernoma in the brainstem, then you're going to see yeah, we have a question from Cruz. Well, I'm going to answer that immediately. So what you want to do is you want to see where it's a little bit yellowish brown, and then you know that that's the place you want to go in. So we're using the Sono PET because we decided that the exposure we've created is still not big enough, and we're using the Sono PET, and now we're using a teardrop dissector. So this is the important head. This is peritrigeminal root entry zone, the safe entry zone to the brainstem, and it's made even safer due to the fact that you have a cavernoma that's already splitting all the fibrous tissue inside the brainstem, and you see all this old venous blood, which is coming out of the small vessels which are in and around the cavernoma. And what we're going to do is just suction it a bit and then wait for our chance to get in. What you're going to see is it's at first it looks like it won't stop bleeding, but it's just old venous blood. So you have to be patient. And what you see is once the bleeding has stopped, even though you've made like just one very small puncture with your teardrop dissector, then this is you're working inside the brainstem. A bad move here can totally paralyze or kill your patient. And I can tell you that in another center there has been a case where somebody tried to drill the suprameatal tubercle, and his drill slipped into the pons and the patient died immediately. So it's not why you're operating a brainstem. It's okay. It's going to be okay anyway. What you saw is the cavernoma had a fluid section on the MRI. So that's what you got at first. You got that fluid, the old blood, which is getting out. And now you're going to be coagulating the small veins and ultimately removing the cavernoma totally. Coagulation of the small vein, you have to do this only experienced people can do this. And this is Dr. Dogo, for instance, of my mentor, Dr. Dammers. You have to have a feeling for this. Which veins can you coagulate? You can't just go on coagulating in the brainstem, because you're going to be coagulating all the small perforating arteries, which are described by Duvernois for those of you who are aficionados of anatomy. There's a very amazing atlas. It's called Atlas of Brainstem Vessels by Duvernois. it's not so easy to get a hold of that. And if you have that, it's a great book to read. Okay, so once you've dissected now, there's a thing here, because if you listen to Spetzer, then he says, yeah, when you're doing cavernoma surgery, then there's always a layer of epithelial tissue which lines the cavity, and you have to pull that out. I don't want to disagree with him, but in our experience, that's very traumatic. So we choose not to do that. We've not had any recurrences yet. We're following our patients. But you know, listen to more opinions and decide for yourselves what works. So we're taking out the cavernoma, and we're not going to insist on taking out everything, all that tiny layer of epithelial cells which are left behind. We're not going to do that. We're just leaving it at that. An enormous cavity in the brainstem, which remained. Now, so this is the postoperative scan. You see just some old blood remains here. This is a case of a woman who was 65, who had a 6-nerve palsy and trigeminal dysesthesia, and there was an inhomogeneous lesion in the petrous apex with cystic components, likely a chordoma. And she said, okay, I don't want to be operated, I want to have proton beam radiotherapy. That's an option. Even better than gamma knife. So she wanted to have proton beam radiotherapy. It was a chordoma. We thought it was benign. It looked benign on the first scan. She came back, it looked like this. Cavernous sinus involvement, carotid fully encased inside the chordoma. This was no chordoma anymore. This was a chondrosarcoma. I don't have any, unfortunately, no movie of this operation. I'm still trying to find it somewhere. So we operated because she had huge progression. She had brainstem compression. All cranial nerves which were involved were. She had symptoms of all of them. She had transient ischemic attacks. So we had to do something. So we operated, and as we approached, remember yesterday? As we approached the petrolingual ligament, but you don't see the petrolingual ligament because you're in surgery and everything's incredibly bloody in this chondrosarcoma. It was all bloody, venous blood, and at one point, arterial blood out the window. What was that? That was the carotid, which was encased. And the carotid was encased, the wall of the carotid, the adventitia and the medial layers were engulfed with tumor. So the carotid was an essential part of the tumor. We had no angiography, so we when I presented it in Marseille, I also said, and I say it right now, when you do skull-based surgery, you have to be able to do bypass surgery. We didn't do a Fukushima type 1 bypass. We just clipped the carotid, and if you remember from yesterday, this is right in the last room. So this is just beyond the petrolingual ligament. So this is we clipped it here, and at first we had good backflow, so we thought she should be okay, but it was a terrible infarction, and she died. So this is a complication which you should always be considerate about. You can injure the carotid, and if you can do a Fukushima type 1 bypass is a bypass where you drill out the petrous carotid and do a bypass there to the clinoidal carotid. Now that's not something that you do. That's something which requires a lot of experience, in doing bypass surgery and skull-based surgery, so it's not something you just do. What happier case? It's a 60. By the way, she, the 31-year-old woman had no deficit, no problems. After 3 months, she was going back to work perfect. She was okay. 60-year-old male with headache and tremor of the left hand, and a beginning Parkinson's disease, and that was actually its tremor, so it's an incidentally found tumor, and then it progressed on a follow-up scan, so we decided, okay, it's a meningioma with brainstem compression, we're going to operate. And this is the operation. You can see much better here what we're doing. So, peeling off the dura, I've said it yesterday, I've said it today. Peeling off the dura GSPN, you're going to see that arcuate eminence is in build. Peeling off the dura is the first step. And then once you've identified your area of interest, we prefer to not use the spatula right away, just as we're going to divide the superior pitosa sinus and tent. So first the sonopet, we don't use that so often as we did in the past. If you ask Professor Fukushima, he says that he actually helped develop the sonopet and they would have named it Fukupet. So this is a diamond burr, and you're drilling with a diamond burr, and what you see Dr. Del was doing, you stop, feel, and then drill again. Stop, feel, drill again. That's the technique. And once you've done that, then you're opening the temporal dura and elevating the temporal lobe. And then here, this superior petrosal sinus, and we're going to coagulate it, and it's really bloody. It's really bloody. Actually, anesthesiology said, okay, do something because it's bleeding way too hard. Okay, so you can control it, search yourself, Novacol, weight, pressure, and patience. And now we're just debulking the tumor on the front side of the brainstem using CUSA and bipolar. And what you do is, all skull-based meningiomas have a lot of skull-based vessels which are going to them. So you have to coagulate the insertion and then debulk. And this was the case, and the postoperative scan was okay. You see a little bit of edema, and you see the apex of the petrous bone, it's gone. I just want to show you one more movie before we finish this talk and we go on to the next one. So what you're seeing here is third division of the trigeminal nerve and foraminal valley, and what we're doing is we're cutting the dura away. We're peeling away the dura from it with a dissector. And here, bony ridge, bony prominence, arcuate eminence, superior semicircular canal. It's going to aid you in what actually, if you listen to Professor Frolik from, he was in Strasbourg, but is now going to take over for Bernard George in Paris. He's elevating the temporal bone and he's placing his spatulas on the tentorial, on the petrous edge. And I just want to show this here, GSPN. And this is where you're going to be drilling out. So he's placing it at the petrous edge. And if you're not attentive, then you see that the bone does a prominence before the petrous edge, which you can confuse for the petrous edge, and you can place your spatulas there. So you have to be very careful. So sonopet, again, using it to drill out the bone with the barracuda claw. There's also Tokyo claw, which has been made famous by Fukushima, again GSPN. And you see that we're now coming on the On the posterior fossa dura, always good irrigation, very important when you're doing this, especially with sonopet, because sonopet can is a very huge drill, but it's also very good, big magnification. It's very important that you're using good, when you're drilling, that you're using good irrigation, and also because of the fact that when you're using the sonopet, it can become very hot very fast. So if you're if you're by geniculate ganglion or facial nerve, then you have to use copious irrigation, because otherwise you can get into trouble. You can have facial nerve palsies caused by the heat which you give from your drill to the bone. So we're drilling out here, sonopet, and now we're going to divide the tent and then dissect the tumor on the anterolateral brainstem. Okay, don't forget the anatomy. Foramen spinosum, medial and anterior foramen ovale. Sometimes you unroof it, sometimes you don't. You can mobilize V3. And then if you follow this, GSPN, petrous carotid, sometimes dehiscence of bone, sometimes not. Geniculate ganglion, meatus, cochlear angle, this is where you're drilling. And the Kawase approach is actually, and why I named my presentation the conquest of the rock. You can conquer the rock, so petrous bone, just by drilling out its most smallest and most insignificant portion, thereby conquering the whole bone. Thanks.